Welcome back to another episode of Surgical Simplified. In today's video, we are diving into two high-yield topics you will definitely come across in your MCQs and SBAs: deep vein thrombosis and organ transplantation. Let's make these concepts simple, logical, and easy to remember. Let's start with deep vein thrombosis. It refers to the formation of blood clot inside a deep vein, most often in the lower limb. To confirm the diagnosis, the most reliable test is a lower limb venous duplex scan. When it comes to the treatment, traditionally we used a combination of heparin and warfarin, but now subcutaneous enoxaparin is preferred. It carries a lower risk of bleeding, and unlike heparin, it doesn't need APTT monitoring. If the DVT is due to a short-term, reversible cause, for example after surgery, trauma, childbirth, or lower limb fracture, we continue warfarin for about 3 months. The unaffected limb should be cared for with physiotherapy and prophylactic stockings to prevent DVT from developing there as well. Now, it's always useful to remember Virchow's triad, the 3 main factors that contribute to thrombosis: stasis, hypercoagulability, and endothelial injury. So, how do we prevent DVT? Mainly by improving circulation and reducing stasis. Encourage early mobilization, use compression stockings, pneumatic compression devices, subcutaneous enoxaparin, and ensure adequate hydration. A few points to keep in mind: antiplatelet drugs are not used in DVT management. Thrombolysis is reserved only for massive pulmonary embolism when the patient is unstable. And IVC filters are indicated when pulmonary embolism recurs despite anticoagulation or when anticoagulants are contraindicated. The best overall treatment strategy is warfarin plus subcutaneous enoxaparin. Enoxaparin has fewer side effects than IV heparin. It doesn't need regular APTT checks, and it carries a lower risk of heparin-induced thrombocytopenia. So that's the core concepts behind DVT. Understand the cause, confirm with duplex, treat safely, and always prevent recurrence. Now, let's move to organ transplantation, especially renal transplant, which is another favorite topic in exams. Before performing a transplant, there are 3 essential factors to consider. Number 1, blood group compatibility. This is a non-negotiable. If the donor and recipient blood groups are incompatible, the kidney will fail immediately due to hyperacute reaction. Second, HLA compatibility. This determines how well the immune system accepts the kidney long term. Mismatching here leads to chronic rejection. Third, conditions of the donor and kidney. Live donor kidneys almost always have better long-term outcomes than cadaveric ones. Now, once a transplantation is done, sometimes the new kidney doesn't function properly. So let's understand the causes of renal dysfunction after transplant. We divide them into 2 main groups: acute and chronic. Acute causes occurring within the first month include hyperacute rejection, acute graft rejection, delayed graft function, primary graft failure, renal veno-artery thrombosis, tacrolimus toxicity, and obstructive uropathy. Chronic causes appearing after 6 months are chronic graft rejection, which is most common, recurrence of original kidney disease, obstructive uropathy, chronic drug toxicity, and infection. So, how do we approach a patient whose transplant kidney is failing? Step 1. Flush the catheter with normal saline to rule out obstruction. If that doesn't fix the problem, do a Doppler ultrasound scan, which helps identify obstruction or vascular thrombosis. Next, check tacrolimus levels to look for drug toxicity, and if all those are normal, the final step is to do a renal biopsy to confirm or rule out graft rejection. Post-transplant complications are not limited to kidney dysfunction. Patients are also prone to malignancies due to long-term immunosuppression. Most common are skin cancers, especially squamous cell carcinoma, and post-transplant lymphoproliferative disorders such as lymphoma. There are also an increased risk of Kaposi sarcoma, though it's relatively rare. Now, a few important contraindications to remember. Active sepsis, previous malignancy within the last 3 years, and multi-organ failure all are contraindications for transplant. But recurrence of the original disease is not a contraindication. In summary, renal transplant is one of the most rewarding surgical procedures. It significantly improves both quality and duration of life when managed correctly. And that brings us to an end of our vascular surgery series. If you haven't seen the earlier episodes, make sure to check them out first. Then challenge yourself with some vascular MCQs and SBAs to reinforce your learning. Thank you for watching Surgical Simplified. Don't forget to like, share, and subscribe to MedVibes for more clear and concise surgery explanations. This is Surgical Simplified.